Thank you everyone for joining us. I'm so excited to introduce my fellow friend and one of our Flip the Pharmacy coaches in Indiana, Molly Nichols. Molly Nichols is a current community practice research fellow at Purdue University, and she has been studying opioid use disorder for a few years now, and she's pretty much a content expert. And we're so lucky to have her on our team and here to discuss some of the questions that you all came up with today regarding opioid use disorder and community pharmacy interventions. Thanks for joining us, Molly.
Hey, thanks for having me, Katie.
Absolutely. Let's get right into it. So our first question today is, opioids and opioid use disorder, or OUD, are hot topics in the pharmacy world right now, and a focus for Flip the Pharmacy in this progression. Can you tell us in general what pharmacies are doing in this space? Are they partnering with government or other programs?
Yeah, so pharmacists are increasingly being recognized for what they can do in the opioid space. The CDC calls pharmacists to serve on the first line of defense in the opioid epidemic, and it's because we can provide so many important interventions. Pharmacists can counsel patients on the safe use of opioids, screen patients for OUD, dispense naloxone, dispense sterile syringes, the list goes on and on. I'm not personally familiar with government partnerships per se, but I would say I've noticed pharmacists start to be more intentional about partnerships in other areas. So I've seen pharmacies partner with police departments for drug take-back events, or partner with office-based treatment programs or individual X-waiver providers to basically direct patients to a single pharmacy for their medications for opioid use disorder, both partnerships have had good outcomes there. And I would say too that pharmacists are starting to branch outside of pharmacy-specific organizations to get more involved in the opioid space in general as well. Some great local organizations that have an emphasis on OUD or substance use disorders in general would be I use Project ECHO, or the Extension for Community Healthcare Outcomes. They have WebExes, webinars every week on different topics on OUD. So that's a good resource if you just want to kind of learn more. And then there's also Overdose Lifeline in Indiana. They've been really instrumental in getting naloxone available to Indiana communities and, again, educating healthcare providers on opioid use disorder. There's ICATA, or the Indiana Counselors Association on Alcohol and Drug Abuse, NAMI Indiana, which is the National Alliance on Mental Illness local state chapter. And then there's also IAAP, or the Indiana Association for Addiction Professionals, which is the NADAC affiliate chapter for the state. So a lot of things going on that pharmacists can jump into to get more involved in Indiana.
That's awesome. Thank you so much for sharing those resources. We'll definitely have to get those linked and out to the pharmacies so they can access all of those links to the different organizations you mentioned. Something else that I know a lot of our pharmacies are interested about is how they can help with this 26 billion national settlement with opioid distributors that Indiana received. So Indiana is receiving a portion of the settlement funding. And can you tell us more about what this means for Indiana? How can pharmacists go about using these funds, or how else could pharmacists get involved to help?
Yeah, that is such a great question. Indiana has the 15th highest rate of opioid overdose deaths in the US, so this is definitely a big problem for our state. And from what I understand, Indiana is receiving $507 million of that $26 billion settlement. And half of the funds that are allotted to Indiana will go to the state government, while the other half will go to local governments. Every single county, city, and town in Indiana has been allocated funds, and the website kind of explaining where those funds are can be found on the in.gov website. And again, like you said, Katie, will link out to these resources so you can kind of look and see how much money is coming to the area that you live. But for example, I live in Hamilton County, and I can see that Hamilton County will receive about $1.5 million of the $507 million settlement. And what I also know is that for both the state and local governments, 30% of the funds received can be used with essentially no strings attached and can go wherever communities decide is helpful. The other 70% of the funds have to be used for specific opioid abatement efforts, which are basically strategies to mitigate harm. So prevention, treatment, all the things for opioid use disorder. And again, the in.gov website links to several different resources here for these as well, including a list of approved abatement strategies. And from the website, I can see that they have 9 core strategies that will be given priority for funding. And those 9 strategies are naloxone training and distribution, MOUD or medications for opioid use disorder, training, awareness, and distribution, services for pregnant and postpartum women with OUD, expanding neonatal abstinence syndrome treatment, which is for women who are using opioids while they are pregnant and their infants are born with opioid dependence. That's neonatal abstinence syndrome. And then also expanding warm handoff programs and recovery services, improving treatment for incarcerated individuals, funding OUD prevention programs, expanding syringe service programs, and then research and data collection on all of these things are the 9 core areas that the state and local governments will give priority to for funding. Specific for pharmacies, I think the naloxone, MOUD, and prevention strategies are particularly pertinent strategies. For example, you could request training for your staff on how to administer naloxone or how to screen patients for OUD. You could request or propose a drug take-back program, but really you could get creative with any of these strategies in the pharmacy, I think. Unfortunately, I don't know exactly how you can put in a request to use some of the funds. I would guess that there will be some sort of proposal submission request at the local government level, but I personally haven't seen anything come through about that yet. What I do know is that Indiana received the first installments of the national settlement in July of this year, and funds are supposed to start transferring to local governments this fall. So I would think that an announcement for how to use, for how to request using funds should come soon. But in general, other ways to support these initiatives besides petitioning for funds directly for your pharmacy is honestly just advertising other opioid-focused community efforts in your pharmacy. So if and when local government starts developing programs or enhancing programs, see if they have promotional materials you could display at your store. For example, maybe your county decides to start a youth education program for safe opioid use. So what a great way to get the word out by having a flyer or a brochure at the pharmacy. In general, I'm a big advocate of this anyway for other recovery resources. I think it can be really helpful to have pamphlets for local NA meetings or treatment programs on your counter for patients to grab if they're interested. And as you know, as pharmacy knows, we know that pharmacies are the most accessible healthcare providers, and patients see their pharmacists 12 times more frequently than their primary care providers. So again, community pharmacies are just a really great place to advertise those things.
Absolutely. Thank you so much for sharing that information. I know that a few of the pharmacies have community resource boards, and this is a great way to use those community resource boards to get some of those efforts and the knowledge out there and display some of those flyers. And then maybe as we find out kind of, this fall, working with those local governments and local health departments to see if you can work together on ways to reach your community.
Yeah.
So then, thinking about our pharmacists in Team Indiana specifically, how can they recognize if a patient at their pharmacy might have opioid use disorder? What should they look for? What are the signs and symptoms? And how can they act for these patients?
Yeah, this is the question, right? There are really 3 scenarios I can think of to consider in the pharmacy when looking for OUD in patients. The first 2 are if someone is actively intoxicated or high in your pharmacy, or if they are actively withdrawing, both of which have more obvious symptoms and might be easier to recognize in the moment. And then the third scenario is if someone is not actively high or withdrawing, but is still struggling with OUD, which can be harder to identify. So thinking about that first scenario, if someone is actively intoxicated, or again, if they're high from opioids in your pharmacy, I would say the biggest 3 things you might notice are 1, really constricted or pinpoint pupils, 2, excessive drowsiness or sleepiness, and 3, euphoria-related symptoms like confusion or potentially hallucinations. If you notice someone is high when they come into the pharmacy, the main priority is making sure that that person is safe and that you, your staff, and other customers are safe. Obviously, if the patient is violent or threatening in any way, follow your pharmacy's protocols for de-escalating the situation or potentially involving the police. Again, pharmacy specific there. But if there are no safety concerns, I would recommend approaching the patient and asking if you can call a friend or family member to come and get them. If you notice potential signs of an overdose, administer naloxone, or recommend to the patient or their loved one, again, when they come in to pick the patient up, that they go home with naloxone. And then as a last thing, if you have a private counseling room, as I know many pharmacies do, I would caution against having the patient wait there unsupervised, because if they start experiencing respiratory suppression, no one is around to administer naloxone. But I do know that's a tricky balance between keeping that person safe and not disrupting other customers in the pharmacy too. But just keep in mind that, again, if someone is high and there's a potential for an overdose, it's really better that someone is with that person. Thinking about the second scenario, if someone is actively withdrawing from opioids at the pharmacy, the main thing you'll probably notice is a general restlessness or anxiety and irritability. Your patient might not be able to sit still, they might have tremors, they might be short with you or easily angered. And really, withdrawal is an incredibly awful, unpleasant, uncomfortable thing to go through. And although patients can't die from an opioid withdrawal, it might feel like they're dying. So to me, it makes sense that if they're irritable or angry. Other withdrawal symptoms that you might notice or that patients might tell you about are super dilated pupils, tearing or a running nose, sweating, achy joints, or just general GI upset, nausea, vomiting, diarrhea. If someone is withdrawing from opioids, it's best practice to recommend that they go to primary care or another facility to withdraw safely and potentially get started on MOUD. But if the patient doesn't want to go anywhere, you can recommend some over-the-counter remedies to make the withdrawal more comfortable. So Pepto-Bismol might help with nausea, vomiting, and diarrhea. Loperamide is also another medicine that's pretty commonly used to help with diarrhea. Antihistamines can help with the tearing up and the running noses, and then Advil can help with joint pain. So we talked to, I've done interviews with patients in Indiana who are in recovery from OUD, and far and away, they all emphasized how uncomfortable the withdrawal process is and how withdrawing is a big barrier to wanting to get treatment for opioid use disorder. So again, I think if pharmacists can help these patients be more comfortable in the withdrawal process, that's certainly, that's certainly good patient care that is needed. And then in the last scenario, where someone is not actively high or withdrawing, but still struggling with OUD, it's probably going to be the most likely scenario that you'll encounter at the pharmacy. Common signs of OUD or just substance use disorders in general are having uncontrollable cravings to use opioids, being unable to cut down on opioid use resulting in persistent problems at work or home, and using opioids despite awareness of the problems or risk that opioid use is causing. A sign that you might see in the pharmacy is a patient taking opioids in larger amounts than prescribed, and so they're consistently requesting early refills. I would say that one might be the most common thing that you see. If you suspect a patient might be struggling with OUD, it's recommended to follow the SBIRT protocol, or the screening, brief intervention, and referral to treatment protocol. Many different screening tools can be found on the NIDA website, which again we'll link out to. I personally like the TAPS and the DAS-10 screeners, since they're pretty short, can be self or pharmacist administered, and give you recommendations for follow-up steps. But again, we will link out to all of those tools, and it's ultimately up to you to decide which tools you like best to screen somebody and which you feel most comfortable with.
Awesome. That's awesome that there are so many actionable tools that we can use in the pharmacy. I know that that's super important to everybody to make sure that we can kind of have a good idea of how to interact with folks, as well as what are the best tools that we can provide for them. So this segues actually really nicely into another question we got, or maybe a little bit of the elephant in the room, if you will. But how the heck do you navigate screening somebody, or in general having a difficult conversation about opioids?
Yes, yeah. Communicating, I think, is definitely the most important, but also probably the hardest part about intervening with OUD. It can be really uncomfortable and emotions can run high. So I'm glad we're spending some time to walk through this. Reflecting back, thinking about that screening scenario, let's say you decide to screen all of your patients who use opioids. Again, it's not always obvious who might be struggling with OUD. There's not necessarily a look to somebody with addiction. Addiction can happen to anyone, so it could be beneficial to screen everybody. Screening everyone might also make people feel less singled out and help avoid putting them on the defensive. So in this scenario where you're screening everybody with an opioid prescription, the next time anyone picks up an opioid prescription, you can say something like, "Hey, we're starting a new initiative at our pharmacy where we talk to all patients on opioids about preventing opioid addiction. Indiana's got one of the worst rates of opioid overdose deaths in the country, and we want to do our part to keep people in our community safe. Is it okay if I take an extra 60 seconds to ask you a few questions?" And then you either have the patient fill out a screening form or you administer the form. Alternatively, you might decide to only screen patients who you think might be struggling with OUD. As you know, there's not exactly an abundance of time in the pharmacy for questions like this. So to be efficient, you might only screen patients who request early refills, who have multiple opioid fills at different pharmacies that you see and inspect, or who have some other red flag that might make you think there's something going on. In this case, you might say something like, "Hey, I noticed you've asked for an early refill on this opioid medicine X months in a row. I have some concerns about this and want to help you stay safe. I have a few questions. Can you help me understand?" Or, "Hey, I'm required to check a state database before filling this opioid, and I noticed you filled this medicine from a different doc or at a different pharmacy X number of days ago. Would it be okay if I asked you a few questions to help me understand more?" And then again, you use a screener. And when I say you here, I'm not just talking about you or me in our roles as pharmacists. Technicians would also be very capable of giving screeners to patients. And this can save the pharmacist time by not having to personally intervene every time and only stepping in if the screen comes back positive. I would say again, if you choose to screen everybody with an opioid prescription, most of those screens are going to come back negative. So there's not, there's not a lot that are going to come back positive that require further intervention. But then thinking back on that SBIRT process, let's say, so you've screened somebody and it comes back positive for risky opioid use or potential OUD. So we've done the S, and now we need the BI, or the brief intervention of SBIRT. The brief intervention should come from a harm reduction perspective. You don't want to come at this conversation from the perspective of getting the patient to stop using opioids. It's better to come into the conversation with the perspective of helping patients use opioids safely. And ultimately, the patient gets to determine what that safe use looks like. So maybe they do want to totally stop using opioids, but maybe they don't. Either way, we can support them to be safer in their opioid use. So I'm sure this isn't a surprise, but motivational interviewing is going to come in big time for the brief intervention. Step one of that intervention is understanding the patient's point of view. You might say something like, "Thank you for taking the time to answer these questions. I'd like to know a little more about your opioid use. What do you enjoy about using this medication? What else?" Maybe they tell you they enjoy the pain relief. Maybe it's being able to do their daily activities. Maybe it's feeling a sense of normalcy. Whatever they say, you can follow that up by asking, "What do you enjoy less, or what do you regret about using this medicine?" And maybe they'll tell you it's some of the side effects. Maybe it's taking away their ability to function at work. Again, whatever the patient tells you, use reflective listening to summarize what they've said. So for example, so on the one hand, you enjoy using opioids because X, and on the other hand, you don't like Y. So whenever possible, make sure to use "and" instead of "but" when you are reflecting and drawing discrepancies. Again, that kind of helps the conversation feel more open and less accusatory. Step two of this process is educating the patient on any risks you've identified or going over the results of the screening questions. Remember, it's important here to ask permission to share information. So for example, "May I tell you what concerns me?" Or "Is it okay if we talk about some of the risks of using opioids? What risks are you aware of?" Or "Would it be all right if we went through your answers to some of the questions I asked?" Here, just tailor the conversation to the patient. Make it pertinent to the risks that came up in the screening. Step three is enhancing their motivation to change. So you could say something like, "Given what we've been talking about, help me better understand how you feel about making a change in your opioid use. On a scale from 0 to 10, how ready are you to do X?" Again, that X being whatever behavior you and the patient have identified is risky. Again, that scale 0 to 10, it's important to give them boundaries. So a 10 would mean you're fully ready to change, and a 0 would mean you're not at all ready. After you ask this, you can ask follow-up questions depending on what the patient says. So for example, why did you choose that number, 7, for example, and not a lower one like 1 or 2? Or if they give you a low number like 3, you can ask them, what would you need to happen to be at a higher number? And then the fourth and final step of that brief intervention is giving the patient a recommendation or helping the patient set a goal. You can restate your concerns to the patient here, and this would also be the time where the referral to treatment component of the SBIRT comes in, so the RT. You can say something like, based on what we've talked about, I'd like to recommend that you talk to your primary care doc about X. Or based on what we've talked about, I'm going to include some information about treatment resources in your prescription bag today for you to look at whenever you feel ready. An intervention I think you can always make with opioids is recommending naloxone. I like to pitch naloxone like an EpiPen. The conversation usually goes something like this. Are you familiar with naloxone? They'll either say yes or no. So I'll either inform or restate. Naloxone is a rescue medication that can reverse a life-threatening breathing emergency from opioids. It's sort of like an EpiPen for allergic reactions, but for opioid overdoses instead. You keep it on hand just in case. I recommend naloxone to all of my patients on opioids in case an accident happens at home with you or a loved one. Would you like to take a dose home with you today? Other interventions that might come up are dispensing sterile syringes to prevent disease transmission, or like we talked about earlier, having those pamphlets or brochures about local treatment or recovery resources readily available for patients. IN.gov has a great treatment locator webpage that we'll provide the link to help you, again, find local resources in your community. And then I do just want to mention that something else we learned from some of those patient interviews with patients in recovery from OUD is that really patients want to have the tools available to them to make a change when they're ready. I would say a lot of times in the initial intervention with the patient, they might not be ready to change their behavior. They might be defensive about their opioid use. It might just be overwhelming to try and change the behavior right then. But one patient in an interview described a situation where they got a pamphlet for a treatment program after being admitted to the ER for an overdose. And although they told us they didn't go right away, they held on to that brochure and pulled it out a couple months later when they were ready to make a change. So again, providing that information, equipping patients with the tools where they can help themselves manage their addiction is just as important as getting them to change their mind right then. And really at the end of the day, when thinking about navigating those sensitive patient scenarios, more than trying to get the words exactly right, you just have to show people you care. In patient interviews with patients in recovery from OUD, we ask them specifically about pharmacists intervening with their opioid addiction. And the patients overwhelmingly said that they just want to feel like human beings. Don't be punitive, be open and curious. They really just want to hear that you care. One patient I interviewed said, it wasn't what the pharmacist told me. She never told me one single thing that I didn't already know or couldn't figure out myself. But the fact she took time to care is what saved my life, nothing else. And I just think that quote's so powerful. Another patient recommended avoiding asking why somebody needs something or does something, as the why potentially puts patients in a position to be defensive when trying to justify their actions. So again, maybe more of that language like, can you help me understand? And then lastly, the nonverbals during these conversations are also super important to patients. Make eye contact, smile, show empathy in your actions and your words. Really just treat patients experiencing OUD like any other patient. They're human, they have a disease, and we can help them manage that disease and live a healthy life.
Thank you for those tips, Molly, and for sharing those patient experiences that you gleaned from your own research. I think we're all wanting to make interventions for these patients and be there for them, but that communication and knowing exactly what is best for us to do for them is something that folks have had questions about. So thank you so much for sharing all of those resources and experiences from your own research as well.
Of course.
I know in there you happen to mention naloxone several times throughout our conversation. So to end our chat for this round of our podcast episodes, can you give us any tips for speaking with different providers about strategies to work together on things like a naloxone protocol?
Yes, absolutely. I think most of us listening will know, but Indiana has a statewide standing order for naloxone that allows any pharmacist to dispense naloxone without a prescription. So you don't necessarily have to go to a prescriber in your area to get them to have a naloxone protocol per se. You can just use that standing order under Dr. Christina Box's name and dispense naloxone at your pharmacy. But I think just in general, kind of communicating with physicians or other prescribers about naloxone, and just kind of, again, being part of and involved in that patient care process. Something that you can do is really, again, for me, I recommend naloxone to everybody on an opioid because, again, you really do never know if something can happen. So a protocol, if you will, at your pharmacy might be that every single opioid prescription that comes in, you ask them if they want naloxone. You might also say that you recommend naloxone for opioid prescriptions that are over a certain MME or morphine milliequivalents. Again, there are recommendations that we'll talk about in our follow-up episode just on what MMEs are and kind of pain things related to that. But again, something common I've seen is having an MME cut off on the prescriptions and recommending naloxone for people who have higher MMEs. Really, again, I would say that that's something that you can do pharmacy specific. I think the pharmacists here have different communities that they're in. So if you're at a pharmacy where, a lot of people are using opioids, or, you're at a pharmacy where there's not a lot of people on opioids, I mean, you can really get creative in tailoring what's going to serve your community best. But then at the end of the day, telling the providers that you do have a patient on naloxone can be helpful too. So you work your magic in the Ecare planning when you're recommending naloxone, right? That's an intervention that can definitely be Ecare planned. And then perhaps you send the physician a follow-up fax or message that so-and-so patient went home with naloxone today, or so-and-so patient, I recommended that so-and-so patient have naloxone at home and they declined. Either way, you're still communicating with that provider and, again, being part of that process. As I mentioned at the very beginning too, going to a provider office and communicating with provider offices just about the services that you can provide. Hey, at my pharmacy, we dispense naloxone. I've dispensed X units of naloxone so far this year. I would also like to help you and your office keep your patients safe, right? That's an easy in. Physicians that maybe are at pain management clinics specifically might be a good place to start out, and then kind of branching into other primary care offices too. I think, yeah, no, go ahead. That's pretty much it.
Yeah, no, I was just going to say thank you so much for your suggestions and even bringing up the Ecare planning. I know something that we as pharmacists are starting to try to be a little bit better about is documenting all those interventions that we make. So, dispensing naloxone to patients and providing them with those resources is an awesome example of something that we can be Ecare planning about.
Yes. And two, going back to the SBIRT process too, screening and briefly intervening and referring to treatment, all of that, document in the Ecare plans, because hopefully we will eventually get paid for our time to do these things.
Absolutely. Well, and I also know Molly alluded to that this won't be our only episode on our opioid podcast here. And next time we'll talk a little bit more about some pain related scenarios. So discussing more about the MMEs and tapering down medications when it's appropriate for patients on Suboxone to take short-term opioids, how to manage new pain for a patient on chronic opioids. So we'll get into the nitty-gritty on more of those pain-related scenarios next time. But I just wanted to take another moment to thank you so much, Molly, for your time today. I know that there are a lot of people looking forward to this podcast, and we're so grateful to have you on our team.
No, thank you. I am grateful to be a team member and glad to share some education on opioid use disorder. Thanks.
Thank you.